Hello, and welcome to Horns of a Dilemma, the podcast of the Texas National Security Review, TNSR. I'm Doyle Hodges, Executive Editor of TNSR. In this episode of Horns, we listen to a discussion between Professor Michele Malvesti of the LBJ School and Strauss Center at the University of Texas Austin and Dr. Julie Schafer. Dr. Schafer is the Chief Technology Officer for Flu Lab and previously has served in a number of leadership positions in U.S. government, including Chief of Staff and later Director of Strategy for the Biomedical Advanced Research and Development Authority at the U.S. Department of Health and Human Services, and also on the National Security Council, where she led the response to biologic threats. This discussion actually is a follow-up on a discussion that was held about 6 months ago. And in this episode of the discussion, we listen in on how the response to the COVID epidemic is coming. We talk about issues related to the development of vaccines and how well the epidemic and the issues that we've encountered with it conform with the planning assumptions and what we can learn to further help our response to pandemic and other biologic threats in the future. Let's listen in.
Well, welcome everybody to a special University of Texas event brought to you jointly by the Strauss Center for International Security and Law and the Clement Center for National Security. I'm Bobby Chesney. I'm the director of the Strauss Center. And on behalf of my colleague, Dr. Will Inboden, executive director of the Clement Center, I want to welcome you all here today for a unfortunately, very timely and definitely very interesting event. It's a sequel to an event we actually held seemingly years ago, but really only 6 months or so ago, just before the pandemic lockdown phase really began. We were fortunate enough to have Dr. Julie Schafer here in person talking with our own Dr. Michele Malvesti, going over the particulars of the government's traditional mode of response to pandemics, how things were unfolding to that stage in this current instance. And now we're back for a sequel event to look in on how things have been going and where they might still go. I'm going to quickly give an introduction to Dr. Schafer, and then I'm going to introduce our moderator for today, Dr. Malvesti, and then we'll get underway and we'll turn it over to them. Dr. Schafer is the Chief Technology Officer for Flu Lab. Flu Lab is a place where they stretch the boundaries of how technology can be used to understand how to respond to and defeat influenza, and more recently, COVID-19, of course. Before she moved to philanthropy, Julie spent 15 years in the US government. Most recently, she was Director of Strategy at BARDA. That's the Biomedical Advanced Research and Development Authority. BARDA is charged with developing vaccines, treatments, diagnostics for intentional and naturally emerging threats, including pandemic influenza and emerging infectious diseases. Julie has served as the Director for Medical and Biodefense Preparedness Policy at the National Security Council at the White House. When she was at the Department of Health and Human Services, Julie co-developed numerous strategies and plans, including the Health and Human Services Pandemic Influenza Plan, elements of the 2009 H1N1 pandemic response. She co-founded a new division in BARDA devoted to accelerating transformative solutions to dire health security threats. Julie, welcome back to Austin, if only virtually. Now, before we hear from Julie, of course, we're going to hear from our moderator, our own Dr. Michele Malvesti, who we're always glad to welcome back. Dr. Malvesti currently serves as Senior National Security Fellow with both the Strauss Center and the Clement Center. It's a joint appointment. And she's a visiting professor who will be teaching this spring at the LBJ School. So when those courses come out, sign up. Her courses rotate across a number of topics, including courses on national security decision-making and on the politics and role of gender in global affairs. During her time in government, Michele served more than 5 years on the National Security Council staff during the George W. Bush administration, including serving as Senior Director for Combating Terrorism Strategy. Michele, Julie, I'm so pleased you're able to be here and give us time out of your busy schedules to do this for us and for our community. And I'm going to turn it over to you now, Michele. Thank you very much.
Great. Thank you, Professor Chesney, Bobby. Appreciate the kind words, and of course, it's a pleasure to share the screen with Dr. Schafer again. You know, during our first conversation back in February, we were in a very different place with regard to the virus known as SARS-CoV-2 and COVID-19, the disease. And at the time when we spoke, when we gathered back in February, the World Health Organization had not yet declared it to be a pandemic. As a matter of fact, it had assessed it and viewed it as a series of epidemics globally, worldwide. But now, today, we are all in a very different place. Worldwide, right now, we have more than 34 million confirmed cases, more than 1 million confirmed fatalities across the globe, and closing in on 207 deaths, again, known fatalities related to COVID-19 in the United States alone. It's important also, though, to note that we have more than 23.6 million individuals across the globe who have also recovered from this virus. The interesting thing is that our understanding of this virus has expanded so greatly over the past 7 months. We're actually seeing science, we're actually seeing our understanding evolve and unfold in real time. So Dr. Schafer, Julie, thank you so much for joining us. So that we can continue our own conversation, our own understanding of this virus and the events. And so for our audience today, I'd like to let you know that we're going to cover 3 broad categories of information. We're going to explore, in the first instance, the events that our planning anticipated and those that our planning failed to anticipate. We're also going to evaluate where we have been successful in our response, as well as where we have fallen short. And then finally, look at pathways forward to a post-COVID normal. So let's begin. Back in February, Julie, we spoke briefly about the H1N1 pandemic from 2009, a pandemic that, quite frankly, most of us in the audience that day did not remember. And you noted that the 2009 pandemic was not the pandemic we had planned for. And so I turn to you today. Is today's pandemic the pandemic we planned for? If you're looking at the current crisis, what events did our planning appropriately consider, account for, and anticipate? Over to you.
Oh, great. Thanks so much. It's a pleasure to be back with you. In many ways, this pandemic is the one that we planned against, is the one that we were so concerned about, that as really globally, starting around 2005, we started doing very serious pandemic planning, saying, hey, guess what? An infectious disease could completely take over the world in terms of the effect on people and the effect on society and the economic effects. And so in that way, yes, we're there. The way that it doesn't really match our planning is that we anticipated it being an influenza pandemic, not necessarily a coronavirus pandemic. And so while there are many areas that in around planning, for example, around what are termed those community mitigation strategies, which include social distancing and can include wearing masks and all of these things that are very commonplace to our existence right now, that was very much something that was planned. The wait to starting a vaccine from scratch is an example of something that wasn't planned because our planning was around an influenza virus, in which we already have a number of licensed influenza vaccines. So the wait for a vaccine would be shorter and the degree of certainty would be greater that we would be able to have a vaccine.
Could you spend a little more time on the vaccine component? Looking at it, you mentioned that our planning did not particularly account for starting from scratch, and our understanding of how long a vaccine typically takes to come to fruition, the acceleration of that, the public-private partnerships, the strong collaboration. Could you walk us through where we are in the vaccine process and what you might anticipate on that going forward?
Sure. So I guess, I'm selling us a little short to say that we are starting totally from scratch, is that we had some understanding about viruses like this from our experience from SARS and which in the early 2000s, 2003, ending in 2004, and MERS, which is another closely related virus. In both cases, we had started vaccine and therapeutics development programs. something that I know that we touched on last time, and you really just can't emphasize it enough in terms of the boom and bust of how we globally respond to infectious diseases, where a lot of resources will be put toward an emerging infectious disease, and then it peters off when something else happens. So either the virus disappears, kind of like SARS did, or other event, we're able to suppress it. It may not disappear like Ebola, but maybe it's controlled, and then five other things happen, and resources and energies go in another direction. So that's to say that we were early, so that vaccine development for those closely related viruses wasn't as far as long as it would have been nice if they were a little further along, because it would make it faster. So I know a lot of folks have seen that it usually takes around 15 years to develop a vaccine. It's a very long and laborious process, and a bit of a roller coaster ride if you're on it. There are some things that are helping us move a little faster than we would have ordinarily. Are some of it are scientific, the understandings about the importance of the spike protein, for example, that is an important basis for these vaccines. We know that from our past experiences from related viruses. We have some vaccine platforms that are able to be, that we think are faster than our traditional platforms. And these are nucleic acid-based platforms that we have great. So like Moderna or something. So those have advanced. Those technologically have advanced, so that we can bring them to bear for this. The other thing, and this is the less magical advances in technology and more about the economics part, is that stages that we would normally do sequentially, we're doing in parallel. Now, the reason that we don't normally do those kind of stages in parallel is because of the financial risk. So as we get later in development of vaccine, later in development, so a vaccine is gone through those early tests, and now it's being tested in humans, and we're figuring out how to scale up manufacturing to be able to make a whole lot. Those are very costly processes. And if something happens in one of those processes that sets you back, the reason to do it sequentially is so you don't lose an enormous amount of money. You only lose a certain amount of money. So in an emergency, we're less concerned about losing that money, because the time that we gain is more important. So that is a very important factor on why we have 11 globally. There are 11 different vaccines in phase 3 studies. Those are the critical phase, kind of the make it or break it phase of vaccine or of medical countermeasure development, in so quickly, where normally it would take years to have that many.
And Julie, educate us. Phase 3, that is the last phase prior to when, for example, in the United States, an FDA might approve a vaccine or consider it to be safe and effective and approve it for wide-scale distribution. Is that correct?
That's correct. So the phases in which they always start at phase 1 is when those phases start with once humans are involved. So phase 1, we're looking for safety. Phase 2, we're learning. Of course, we're always gaining information about safety, but phase 2, we're looking at safety, but then we're also looking at getting the dose just right and getting some early signals on how well the vaccine will work. Phase 3 is having the vaccine in a lot of people, gathering a lot more data on how the vaccine performs, and to get a sense for how efficacious the vaccine will be, and then to gather even more data about how the vaccine is in people, because humans, there's a lot of variety in humans, as we all know, and so it's important to test medical countermeasures, to gather experience of a lot of different people. So it's important to have so that's another reason it's really important to have clinical trials represent what a population looks like, so that we can gather that experience.
Dr. Schafer, what assumptions did we make early on, either in the planning or, quite frankly, early on in this crisis, that perhaps no longer hold today based on what we know now?
Sure. And I think, you mentioned at the beginning, and honestly, we could say it every sentence and it isn't saying it enough, is that what's really challenging and uncomfortable and really true is that we are living science in real time. So that means that our assumptions are continually needing to be updated, and our policies and guidance need to be continually updated based as we learn more. And that's confusing and challenging and also really important. So a great example of that, well, I guess it's not a great example, an example of something that's really confusing and is still unfolding is the importance and use of antibody tests. So, or serological testing. So the idea, what is a test like that looking for? It's looking for evidence of a prior exposure to the virus. So right now, since we don't have a vaccine, that would be an infection. When vaccine is readily available, one would have antibodies. Presumably, one would have antibodies also from the vaccine. They should be. Hopefully, they're very hardy antibodies. Earlier in the pandemic, and again, it's hard for that not to feel like 10 years ago, but it was just months ago. We were and I think probably there was some hope involved that, hey, if we can do these antibody tests, we'll get on an individual level, we can get an understanding of that person, if perhaps those antibodies, that is showing immunity to the virus. So if that test was, say, positive, there are antibodies there, that would mean that person was immune from a subsequent infection. What we're finding is we don't know what it means, and we're getting signals that if there is immunity, so let's say that someone had an infection and they recover and maybe they have antibodies. We don't think that the immunity, if it exists, lasts as long as that we want, and some people may not have ever experienced it. So we're getting some more evidence of people who were known to be infected who are now getting known to be reinfected, and so that makes so if you remember, or if it jogs any memories, there talks about things like immunity passports. Before there's a vaccine, so that was the idea of like using an antibody test, like, oh, see, I am safe, I have these antibodies. While we're waiting for a vaccine, that just may not be the case. That's just another example of that. So we've got these tools which include testing for infection and testing for antibodies, but then how we use the results of that are going to continue to evolve as we understand more.
So given this particular virus, SARS-CoV-2, we don't yet know what herd immunity means. Is that correct? Okay, and could you walk us through, and maybe it might be helpful to compare and contrast herd immunity, what we might have expected with this virus, or what we're thinking about, versus herd immunity for influenza. Does herd immunity work for influenza? Just could you spend a little time with us on herd immunity
Sure.
and how we should think about that going forward?
Sure. So something that's it's useful to remember is that viruses need to hitch a ride. They can't just hang out on their own. They need to be somewhere, and they need cells to do anything. They need to latch onto a cell and then use a cell to replicate and to do anything that a virus would want to do if viruses have wants and desires. Probably not. So the concept behind herd immunity is making it more difficult, or making it more challenging for a virus to be able to transmit to someone else. So if I am an infected person, and 4 out of the 5 people that I could transmit to all have immunity to the virus that I'm infected with, that virus only has the chances of the virus being able to infect someone else and then make another transmissible vector, I guess, decreases dramatically. So the herd immunity there. So in different pathogens have different require a different percentage of herd immunity of immune people in a population to achieve herd immunity, depending on how transmissible the virus is. So if a virus is highly transmissible, like measles, you need a very high percentage of that population of, like, say, those, like if we had 100 people, you need a very, very high percentage of those 100 people to be immune via vaccine or prior exposure, in order for that virus to have nowhere to go. Other viruses that are maybe are less transmissible, maybe that percentage doesn't have to be, everybody. So we don't know exactly what the percentages would be for SARS-CoV-2. For influenza, what's tricky about influenza is that for lots of reasons, I always like to frame them as kind of sloppy replicators. Influenza viruses are constantly changing. They mutate at a very rapid pace. And so the immunity that we might, so if I'm vaccinated for a particular influenza strain, or I have a natural infection for that influenza strain, and let's say that there's immunity conferred for that, because the viruses are changing, I would probably be less likely to be exposed to that same virus again. It would have changed in a way that would make me vulnerable again. So, and also because our influenza vaccines are imperfect, perhaps the immunity that is provided by them may not last as long as we would like them to, which is another reason why we make a lot of investments in improving influenza vaccines.
Thank you for that, Dr. Schafer. Let's pivot a little bit away from the assumptions and kind of look at our evaluation of the current response. And back in February, you made the point, and we discussed the importance of a foundation of partnerships being critical to the nation's and the world's response, a foundation of partnerships that extend at the global level, such as the World Health Organization, pivoting down then through national level governments, down to state and local municipalities, communities, individual citizens, the role of the private sector. And so as you look across this foundation of partnerships in this current crisis, are there particular efforts that you would highlight where we have been successful in terms of our response?
Yeah, I mean, I think that it's helpful to think about it at many different levels. I think that the United States is not a part of this initiative, but I think that what will be interesting to watch for the success of is the COVAX initiative, which is led by Gavi, which is kind of a organization that promotes and makes available vaccines around the world for equitable, so shared risk and shared access to vaccines. So that's the idea. So kind of going up against, often in a pandemic, we think almost like an arms race where countries can be pitted against each other because there's only a certain amount of vaccine available, and then countries are kind of fighting to get access to it. So COVAX is this idea, okay, we're going to, these countries, some of which are very wealthy, some of which are not, are going to agree to kind of hitch their wagons together. The U.S., through Operation Warp Speed, has chosen to concentrate on making sure that there's access. So putting in supporting 7 different vaccine approaches to speed the availability of those vaccines, and the idea of supporting it would be able to gain access to those vaccines. So there are 2 different approaches. Time will tell which will be I hate to say best. There are 2 different approaches. I'm sure we're going to learn a lot from both of them. And I think because pandemic planning assumptions had been for a very strong national kind of a coordinated response, and that has not occurred for a number of reasons. And so what has been interesting to see is where states and governors of states have coordinated amongst themselves and to address some of the challenges of the response, and we may see more of that as vaccine becomes available and they're thinking about distribution. So I think absent that federal down response, where we see more on a state level of coordination amongst governors.
Could you spend a little bit of time on clinical care and the changing medical situation? And you can look at it even questioning perhaps some of the assumptions we might have had early on, but where we're also seeing in terms of a response, a quick adaptation or an adaptation to a quickly changing medical situation. How has the response planned out, both in terms of what we might have anticipated, in terms of the assumptions, and how we have responded?
Sure. And I will do my disclaimer that I'm a doctor, but not that kind. So I will be clear that I'm not providing any sort of medical advice. But, I think that it is a clear example of what you can see as we learn more about how to respond, how to understand what are the things that work. Early on, you can really feel for clinicians, because there isn't a magic wand. They're trying to gather, information almost like in the dark. Imagine blindfolded and kind of feeling around a dark room, trying to say, okay, trying to adapt. And so a couple of things that are really important around that is sharing, is clinicians sharing information and researchers sharing information. And this is another example of why it's so critical, where open science is so critical. And we can see the increased prominence of things like preprint servers, where papers that aren't peer reviewed will go up on a preprint server, clearly marked, hey, this is not peer reviewed. Like this is happening in real time, but getting information out while it's going through a peer review process. So we're getting information out so that clinicians have information so that they can adapt to their situation and provide the better and better care. And so it's like so more data are going into the system, and we see that. And we can see the effect of that in decreasing mortality and because they understand which tools to use and when, and of course that's going to continue to improve.
Julia, it might be helpful for members of our audience to understand perhaps where other countries stand in the fight, or perhaps other particular measures that other countries have taken that we have not yet, or that particular areas of our country have not yet experienced. But, as you look across the globe, and given your deep domain expertise in terms of pandemic planning and response, are there any countries, cities worldwide that perhaps stand out to you, either positively or negatively?
Yeah, I think so. I mean, I think we can all clearly look at New Zealand and say, oh, wow, like that's, and the way that they had a pretty strict lockdown, and then were able to reopen the country. And when they did have, and I think in Auckland, they had a reemergence, so they locked down again. But the rest of the country was able to, they were able to contain and stamp out. Now, of course, they're islands, so it's a little bit, so it's not as directly comparable to the American experience, where there are a whole lot more of us. I think we can also look at their neighbors in Australia, where they have also chosen to have very strict lockdowns when there have been outbreaks. For example, Melbourne is just now starting to lift measures from a very strict lockdown in which residents were allowed out 1 hour a day, while the rest of the country, which was not experienced these outbreaks, was kind of going about their lives. So there are factors that allow that. There has to be a lot of trust in institutions, which is something we talked about in the last time you and I were able to be together. And kind of a trust that they can kind of see the outcome that there was an agreed upon outcome that everyone was searching for. And I think those are the areas those are some elements that enable that kind of success. Europe, different countries in Europe, I think Sweden is a country that a lot of folks look to. They didn't lock down like most countries in Europe did. They chose not to lock down. They kept most things open. They did limit the number of people, so like a maximum of 50 people, and then in places where there would be large gatherings and smaller, and lots of hand washing and things like that. They did experience a lot of losses in nursing homes, and so we see a lot of kind of uneven experiences. I think that and we can look at some countries in Africa that had more recent experiences with Ebola, and something that that I think you and I have talked about offline is a mindset that folks had a mindset of responding, of kind of like a pandemic, or an epidemic mindset that enabled them to kind of everyone agreed, have again that common goal of, we don't want this virus here, so we're gonna take these measures seriously.
No, I appreciate that. And you and I spoke that some of the countries in sub-Saharan Africa, and particularly West Africa, because of their experience with Ebola, provided a baseline understanding and infrastructure and experience that they were able to carry forward to address this current crisis. Let's turn a little bit towards the future, perhaps, and pathways forward for a post-COVID normal. I know so many times I focus on, when will this crisis end, but let's take a different approach to it. Dr. Schafer, how does this crisis end? I mean, so, back in February, you educated us on different, interventions, the pharmaceutical interventions in terms of therapeutics, vaccines, and then the non-pharmaceutical interventions, the social mitigation, community mitigation interventions of what, quite frankly, when we discuss telework and schools closing down and the canceling of mass gatherings back in February, in many ways, it still seemed very abstract, but now it has engulfed all of our lives. So, some of us might be pinning our hopes on a vaccine, but I know that you've educated us a bit on, it's not necessarily that it will supplant what we're doing now, but it'll supplement the current community mitigation measures. So Dr. Schafer, how does this end? What does success look like?
Right. Well, thank you for not asking me when. So I appreciate that. So yeah, I think what you laid out is exactly right. The vaccine is most likely not going to be, or vaccines, plural, are not going to be a panacea. I mean, maybe they will, but perhaps best not to think of them that way. They will be a really critical tool in creating, and even an imperfect vaccine or imperfect vaccines will be a really critical tool in creating immunity in more individuals in a population. How long will that immunity last? Well, gosh, even if that immunity would last 6 months, we could really decrease the opportunity for transmission in communities, and just stamp out the transmission in communities if we have enough people, we have enough immune individuals, even if it's not as long as we would want it to be, and then we pair that with increasingly better or more options for treatment. So those who do become infected and become severely ill are able to be treated effectively. We also continue to do testing and expand our thinking about what testing looks like. I'm really heartened, but as we have more tests that maybe are not as sensitive, that means able to detect an infection to the degree that you'd want if you went to a doctor's office, but maybe they detect 90% of infections, so you could use them, but they're really cheap. And they can be used in lots of different settings. And so you can have more testing. And if you can capture, say, someone has a very high viral load and would be able to transmit a lot of virus to others, you could take that person out of a group of 30 people. Think of what you could do in terms of reducing transmission in a community. And then we will continue, another part will be to continue to have, some forms of social distancing. Maybe it looks more like the Swedish model, where things are open, but not with as many people. Those are all, some, I believe that all of those have a place to get to the place where we want to be, where the virus is not transmitting in communities, and we're able to return to a life that is closer to what we experienced before.
So I'm hearing vaccines combined with a host of other non-pharmaceutical interventions with an added layer of expanded testing. Is this what we're hearing?
That is my personal recipe. You heard it here first. And I think that is, and it certainly is my understanding from listening to other folks who work in this space is that it is a combination of that, and some may emphasize some elements more than others, but those are kind of the toolbox that we're working with.
Thank you for listening to this episode of Horns of a Dilemma, and please don't forget to visit our website at tnsr.org.